Good morning, students. Today's class we'll see about the admission to neonatal intensive care units. Guidelines for admission to a level 3 NNICU is birth weight less than 1,250 gram, gestation less than 30 weeks. Some infants born between 32 weeks may be admitted in a level 3 because of staffing acuity. Requirement of intermittent positive prayer ventilation, requirement for an oxygen transfusion, any other baby whose clinical condition is such that they cannot be appropriately cared in level 2. Level 3, level 2, level 1 I have been clearly explained in one of the other video which shows the levels of neonatal care. So if you don't understand what is level 2 and level 3, please go and see that video too. Guidelines for admission to level 2. Low birth weight, that is under 2500 gram. Some babies between 2000 to 2500 gram may be able to go directly to the postnatal ward. It will depend upon the clinical assessment of the baby and whether the postnatal ward is deemed likely to provide appropriate level of care or not. Prematurity, 36 weeks of gestation or less. For babies born between 35 to 36 weeks of gestation, criteria it is applied for the first one. Infection, suspicious of infection together with clinical concern. Respiratory problems like apnea or cyanotic episodes, any respiratory distress causing concern, persisting signs of respiratory distress for more than 1 hour. Gastrointestinal problems like feeding problems severe enough to cause clinical concern, bile stain vomiting or any other signs of supportive bowel obstruction. Metabolic problems include inability to maintain serum glucose concentration greater than or equal to 2.6 millimole per liter despite of adequate feeding. CNS problems like convulsions, moderate birth asphyxia, which may require monitoring for initial period to ensure problems do not ensue. Malformations like congenital malformation that may require interventions unavailable in the postnatal ward or initial period of observation like Piger-Robin syndrome. Cardiovascular problems requiring monitoring or interventions unavailable on the postnatal wards. Miscellaneous, any baby that is causing concern to such a degree that an attending doctor or an advanced nurse practitioner feels that the baby requires observation or treatment in level 2. It's better for a baby to be admitted unnecessarily than for a baby requiring admission to be left on the ward. Socialist 2. Such babies ideally be nursed on the ward with parents or at home. On occasions, circumstances dictate the babies require a period of care in level 2. Equipments and setting up of admission neonatal unit. A pre-warm incubator, sterile water irrigation for humidification, incubator bedding with suitable nesting and weight nappy, ventilator with oxygen air plug-in, oxygen flow meter, neonate cuff and face masks in different size, suction unit ready to use and selection of suction catheters, monitor with attachment, ECG leads with 3 electrodes attached, saturation lead drop with posi wrap, selection of blood pressure cuff, infusion pumps, syringe pumps, fully stocked neonatal trolley, nursing charts and iliac medical notes. Discharge of low birth weight infant. The infants who has been born at very low birth weight or low birth weight represent a risk of children. Increasingly, they are being discharged at home being at 2.5 kg. Following guidelines necessary when they consider discharge from that infants. Baby has to be gain weight. Does not have to be reached any particular weight, however, as long as there is a weight gain. Baby has to be sucking all feeds. If the breastfeeding is being established, it is not a prerequisite that the baby is on full breastfeeding prior to discharge, provided we are happy that the baby is able to suck strongly. However, we must be sure that the mothers are aware of the need to continue monitor the progress once further feeding changes are made at home, that is, switch from complementary to full breastfeeding. Baby must be able to maintain his or her temperature in accord with normal household environmental temperature. This is particularly important when discharging low birth weight babies home in the winter. And parents must be happy and willing to take the baby home to have a demonstrator that they have acquired the parent skill. This may be a self-evident, particularly when there have been other children in the family, although not always. Some basic information should be known about the home environment and community to which the infant is going. That is, if they are living in a remote area in a caravan, or one would like less likely to be affected discharge home at low birth weight. There should be adequate community follow-up service available. It may be appropriate to contact the general practitioner by telephone to discuss the follow-up. In remote areas, details should be known about the availability of a well-child service visiting. Neonatal home care nurses will be able to provide some initial support and follow-up, provide liaison of ongoing community follow-up.